All right. Well, welcome everybody to our monthly Doxy.me research grand rounds. We're really excited to have you all here. Today's presentation will be by Dr. Triton Ong, who will be presenting on current and future demands for remote treatment of phobias. And really excited to hear about this. And go ahead and take it away, Triton.
All right, thanks for that intro, Brian. Let's go ahead and get started. First, I want to introduce ourselves. We are the Doxy.me research team. Here in the company, we focus on telemedicine research. Not only do we conduct and publish our own original research, but also reading and synthesizing the research of other people in the field. One of the things that we do as part of that is obviously reading a ton of research. And there's always going to be more research out there than can ever be read. But as part of our processes, we do like to once in a while reflect on all the research that we read and kind of read between the lines and point out things that are happening, patterns that we're seeing in that research literature. So this talk is going to be based on one of these publications that we put out on the symbiosis of virtual reality exposure therapy and telemental health. It's an opinion piece and partly a narrative review of research that we've been reading over the past couple of years, and basically a case for combining these two technologies. But like any good academic talk, we're going to start with that juicy bit and then go back a little bit to talk about history, context, theory, a little bit of the fun stuff. So I don't think it makes sense to talk about virtual reality exposure therapy without first talking about exposure therapy. And exposure therapy is really all about phobias. So phobias in the formal mental health diagnosis aspect are an acquired fear plus the related anxieties that come with that fear. And this is not just like I'm kind of uncomfortable around this thing. These are fears that are so intense and so pervasive that this negatively impacts a person's life. They cannot go outside. They cannot form relationships. They cannot hold down a job because this fear has become so intense. Um, the important thing to know about how phobias happen are here on the left in this notation. I know it looks like math. Don't worry, it's not going to be on the test. But basically, there are certain stimuli that when a living organism is exposed to it, it elicits a reflexive response. Reflexive as in it is inherent in the organism, it is untrained, and it tends to be pretty fixed. These reflexes are present in human beings. They are present in dogs. They are present in lizards. They are present in single-celled organisms that are over 1 million years old. So as far as we know, these processes are pretty much the same in any living thing that we've seen, which makes it quite common and quite understandable, but nonetheless very difficult when a person is afflicted by it. So to put this in an example that we can all understand, pain is an unconditioned stimulus for fear. When you're exposed to something that causes pain, you naturally unavoidably feel that fear response. That's a normal thing. That's obviously very adaptive, very evolutionary selective. You don't want to feel pain because pain is your body telling you you're receiving damage. So learning to avoid pain, that is to have the fear response to pain, is very good. It's natural. But the unfortunate thing is that if that pain is paired with something that's neutral, something that on its own doesn't cause any particular reaction, the response can generalize to that stimulus. We call that a neutral stimulus. And then, for example, here, a needle causes pain and the pain causes fear. But if it's the doctor administering the needle, you can come to fear the doctor as if the doctor is the one who caused the pain. Another nasty aspect of fears is a plus and a minus. Again, this is highly adaptive, but fear has a tendency to generalize to other stimuli. Obviously, we might characterize people as neurotic, as paranoid, as anxious, what have you, but it's the people who learn to fear that survive better. So it is, again, a very natural thing. But in this case of the doctor being the feared response, or the feared stimulus in this case, it might be the case that next time it's a nurse, or next time it's a physician assistant, or next time it's a surgeon who's not a physician, not the physician that you saw the first time, but nonetheless, it is these people wearing these uniforms that administer procedures that cause pain and then cause fear. So now you're not only fearing the doctor that gave you the shot, you're fearing all people who wear these uniforms. And you can see how this spirals into these patterns where a person's life can become debilitated by this condition. Now you're seeing uniforms everywhere outside. You're seeing garbage men. You're seeing mail people who deliver mail. You're seeing cops and stuff like that. And this can really narrow a person's options. The good thing about this process being so fixed and understood is that it's relatively straightforward to treat through systematic exposure without the fear, and that reduces the fear response. In other words, it's this area here with the conditioned stimulus and the conditioned response. That's a relation you have to break. And this form of therapy is what we call exposure therapy. The really good thing about exposure therapy is that it's the gold standard. It is the first line treatment for phobias. The symptom improvement is almost immediate if it's done well. Somewhere between 60 to 90% of patients who undergo exposure therapy will be cured of their phobias. They'll no longer meet diagnostic criteria for having the phobia. When they are cured of their phobias via exposure therapy, they tend to not relapse back into that same phobia again. And even though the procedure can be a little bit uncomfortable, most patients by the end of it say that they enjoyed it. It was good for them, and they're glad that they did it. That being said, exposure therapy can be really difficult to conduct in clinical office settings. Number one, it's impractical to expose people to their phobias sometimes in clinics. If you think of like a height phobia, someone who's afraid of being in high places, not all of us have offices on like the 80th floor of a high-rise building. So you got to find a high place that will let you do sessions and stuff like that. You have to get there. You have to convince the patient to get there. You have to convince the people who own the building to let you do therapy. And it just can get really, really complicated really quickly. It's also stressful, especially for the provider in this case. I myself am not phobic of spiders, but if I was treating someone who was phobic of spiders, well, now I have to have a box full of spiders in my office. Where am I going to put that? Do I need someone trained to operate, handle, manage the spiders in my office? Do I have to worry about staff and how they're going to react? What if the spiders get out of the office? What do I do then? So you can see how this can very quickly get complicated, and it drastically increases the complexity of therapy. There's also a concern by some providers that exposure therapy could be potentially dangerous for patients. What if the patient has a really strong reaction that I wasn't ready for? What if the patient is experiencing fear, but they're not telling me and I'm making it worse? There are a lot of concerns around this kind of thing. And unfortunately, while most providers know, they will easily tell you that exposure therapy is the go-to treatment for phobias, as many as 87% of mental health providers choose to not use exposure therapy for phobia treatments. And when you look at this on the global scale, of about 3 to 15% of people around the world experience phobias, only 1 in 5 of them actually seek treatment for it, because there's still a lot of stigma around this kind of disorder. It's seen as like a character flaw of like, just stop being scared, bro. It's kind of, that's the reaction people get to phobias. People don't think it's a serious disorder, but the tragic part of this is even if you did seek care for this, less than half of the people who seek care will actually get effective treatment. And this is where we get to virtual reality exposure therapy. This has been something that people have been working on for decades at this point, and it's a really proven technology that enhances an evidence-based treatment. You can see here on the left, there's one picture that shows what the clinician sees. This is their control panel where they can press all the gizmos to tell the simulation what to do next based on the responses of the patient. And the patient is here on the right in the headset undergoing the therapy. So with virtual reality, obviously, it's easier for the clinician to manage because you don't have to have the phobic stimulus, or you don't have to arrange for the phobic situation in your office. It's all computer simulated. All you need is the headset. And for the patient, it's really easy to convince people to try this therapy when you know you don't have to physically be in the same room as the thing you're scared of. And because it's virtual reality, because it's so immersive, you do end up getting the same responses as you would with a real life situation. So virtual reality exposure therapy has proven to be very durable, very effective, just as effective as normal exposure therapy in clinical settings. It's also very scalable. It's easy to distribute these devices around the country. It's safe because you're not actually touching it. And then it's engaging. Patients generally like the novelty of virtual reality. It's easy for them to try, easy to convince them to try. And if you look at the history of the research with virtual reality exposure therapy, it has broadly followed the development of these consumer devices. Anytime there's a new thing that's cheaper, slicker, slimmer, lighter, easier to use, someone will eventually publish a study on it for exposure therapy. And we're kind of spoiled for choice these days. And towards the end of 2019, this became a commercially viable business. There are a number of big name companies out there that are publishing on this kind of thing, and they offer services and even hardware kits you can rent out, and they'll mail it to you for use with clinical therapy. So towards the end of 2019, we were seeing virtual reality exposure therapy on somewhat of a mainstream trajectory. 2020 comes around, some stuff happened. Let's kind of talk about it. The pandemic impacted a lot of healthcare and a lot of people's daily lives. It affected everything for everyone, basically. We were all told it's dangerous to go outside. It's dangerous to see your loved ones. Stay at home. Don't go out. Whatever you do, don't go out anywhere. And all we had to do while we were stuck inside for basically 2 years was sit and watch screens of what was going on in the world. And it wasn't great. Daily death counts was said like it was the weather report. Images of dead bodies in ICUs and images of people crumbling from the disease. It was horrible what we were seeing from the disease itself, but then there were also other terrible world events that were highlighted and repeatedly broadcast, including police brutality and widespread civil unrest that arose from that. There were an endless string of natural disasters that did terrible damage to ecologies, economies, and people's lives, and just images that we were seeing of totally helpless situations. The resource shortages that came from the pandemic caused all kinds of conflict and is frightening imagery of resource shortages, and the potential of collapse was something that was repeated over and over again. We were seeing people getting violent over toilet paper. And while we were on these screens, it turned out that a lot of these companies that run these social medias platforms have been manipulating our feelings with intent, and they're now being investigated openly. And it's undeniable that even the things that we trust to connect us are not in our best favor. A number of other things happened, especially with global warming, where authoritative institutes told us there's nothing we can do anymore. It's over. The impact is done. Everything's going to get worse. We kept seeing all these images around the world of terrible things happening to normal people for no reason at all, and there's nothing you can do about it. And even the best laid plans, the best intentions, it doesn't matter. It's just going to get worse. So this collective event is now considered an intergenerational trauma. The World Health Organization has noted that anxiety and depression diagnoses have gone up by 25% around the world. The American Pediatrics Association recently declared a national emergency based on the impacts this is having on children. Mental distress symptoms have been reported in up to 82% of the general population. 1 in 5 people are now considered at risk for serious mental illness. This is mental illness so bad that it negatively impacts your life. And around this, we are seeing coronavirus pandemic specific phobias emerging. People afraid of screens because suddenly kids are now learning from home. People afraid of their cell phone because now they're getting messages while they work at home at like 3 a.m. People afraid of being in public places. People afraid of being around strangers. All kinds of new fears emerging from this event. And collectively, what we think this presents is a very clear present and future need for technologies like virtual reality exposure therapy. But while virtual reality exposure therapy is great, it has been mostly studied in clinics, and we think this needs to be more accessible, and greater mass deployment is what we need from this going forward. So let's talk about now why we see good overlap between virtual reality exposure therapy and telemental health. There are a lot of complementary benefits here, where these respective technologies have pluses and minuses, and they kind of assist each other in ways that they can't do alone. So we're about 2.5 years into this pandemic, and telemedicine has been a great help to a great many people. But at this point, what we are hearing is that it's not the same as in person. It's good, but it's not the same. There are some things that are missing. There are some things that I wish I was in person to get this, because I don't get it from telemedicine. It can feel a little bit sterile. It can feel a little bit hard to communicate. Whereas virtual reality is based all around that flow, that immersive, that present communication. So there's a lot of interesting things that you can get from virtual reality that you can't get with just regular telemedicine. A good thing about telemedicine and telemental health in particular is how accessible it's become. It's available through basically any device in your home. You can get it wherever you are as long as you have internet and power. And it's great. It helps a lot of people, and people really like that it's accessible in that manner. Virtual reality exposure therapy to date is still largely clinic-based. You have to go to a person's office for this. You have to dedicate office space to this equipment. And again, with the stigma of phobias, that can be a difficult ask, even though it's more convenient than ever. Imagine if you could get this therapy from home, where you don't have to go anywhere, where you don't have to potentially be seen in a waiting room and things like that. A lot of telemedicine is still manualized procedures that is clunky and is adding a lot of administrative strain on our providers. We hear stories all the time of providers having to physically mail forms to their patients and then have those forms filled out on hand and then mailed back to them in their office, where they enter it into a spreadsheet and do all this stuff. If you're interested in that kind of workflow stuff, then Dr. Hiral Soni has given a couple of talks that you can check on the YouTube playlist about DocBot and automated data collection. But as it relates here, virtual reality is essentially a series of complicated sensors that are constantly communicating to each other. And that presents opportunities to automate a lot of this data collection, to digitize a lot of this data collection. If you think about when you're in virtual reality, you as a provider, you can like hold your controller, reach into your backpack, pick which form you want the person to fill out and give it to them. They take the form in virtual reality, fill it out. And for you, all it does is it puts information in a database that you can get later automatically. But for the patient, it feels like, that natural process of going through a form and going through information together. One of the other things about telemental health is that it tends to be static. These are webcams, let's be honest. They don't do a whole lot. They don't track a whole lot. And as a mental health provider, you are sort of just observing a person undergo changes with standard telemental health. But in virtual reality, you are part of that experience. You are in that experience with them. The patient can see you in the space with them, manipulating the objects, undergoing the experience. You're a more dynamic part of that exchange. So to get to this promise of all these things that we just said here, there are a number of things that have to happen. Number one, user experience research and design. Virtual reality, as it stands right now, is not very usable. We all have virtual reality headsets, and we were just talking about this the other day. They're kind of collecting dust for a lot of us. It's not because virtual reality isn't good. It's just that it's not worth the effort that it takes to get to the good part right now. I have an image here on the right that is a decision tree that we use internally for how to set up virtual reality meetings. Those instructions are 3 pages long. You have to register for 2 separate accounts. To get those accounts registered, you have to take your headset off, take your headset back on, take your headset off again, get a code, use your phone to authenticate, and it's a nightmare. If this stuff is not usable, providers are not going to be able to engage with it. So the number one thing that has to happen with VR is it has to get easier to use. The second thing that has to happen is the lifeblood of providers, which is HIPAA compliance, and not only just for legal purposes, but protecting the privacy of the patients. Because again, remember, this is mental health. These patients are very nervous about getting treatment. They don't think it's worth their time. They don't think it is something that they want other people to know about. So given that a lot of these devices, especially the big ones right now, are not HIPAA compliant, this is a big barrier here. There's a lot of talk about maybe we shouldn't be using these devices at all. So to advocate for the safety and privacy aspects is going to be a very important roadblock here. There are also limitations of the devices themselves that effectively limit the value of therapy. In virtual reality, it's great. You can see movement. You can see, it tends to be low latency voices, but you can't see facial expressions. And that's a huge part of therapy, is seeing how someone feels about things, seeing how someone's reacting. The subtle interactions that happen with nonverbal communication don't translate to virtual reality. But towards that end, a lot of companies are working on this. And what needs to happen is these devices need to be tested for their utility for clinical purposes. Obviously, with all this fancy equipment we're talking about, costs and accessibility and digital divides is a big topic. If people can't afford this stuff, then why are we even doing it? And obviously, when it comes to mental health, it's always been the case that the people with the greatest need are the people who will never be able to afford this stuff. So we need to be talking about economic models for how to distribute this and looking at what makes sense? How do we make this make sense? And I think the VA hospital system here in the United States is a good example of someone who does this all the time. They recently bought tablets for all the veterans in the rural areas and just sent them out because they did the math, and it turns out the cost of a tablet is very little concerning, or when you consider the cost of people not getting care. So models like that, collaborations like that need to happen in order to make this accessible. And in terms of those models and where those costs come from, we need to reduce the uncertainty on that aspect. A lot of these VR research, even though they're really good, they exhibit really good effects, their effects are limited to maybe like 3 to 6 months. And mental health is a lifelong thing, so we need longer term data. And then we also need people to publish on how much these costs turn out to be. We know that there's research showing that $10 of VR equipment, just using a Google Cardboard with a phone you already have, is effective. But how effective compared to other treatments? How durable are those effects? How long do those effects last? And for major stuff like big trials on PTSD, they have found in the past that all the costs related to virtual reality exposure therapy amount to about $114,000 saved compared to recruiting and training a new soldier. But again, that's specific to military PTSD. What about other forms of PTSD? What about people who are not fighting age young men? What about children? What about elderly people and things like that? So while the research so far has been really good, they tend to be narrow in focus, and it's just there are a lot of questions that people have when they talk about the efficacy of these devices. So collectively, those are all navigable, very easy, but this is always going to depend on open collaboration between all the relevant stakeholders. So for researchers, we need to really look at our study designs, the measures that we're using, the populations we're studying and recruiting in our studies, and the way that we measure outcomes needs to improve here. And towards that end, researchers have proposed this 3-stage model where stage 1 is basically exploring. Stage 2 is demonstrating initial feasibility, and then stage 3 is doing large-scale randomized clinical trials and getting long-term data. So models like this are going to be important for guiding researchers on what needs to happen in terms of producing data that is usable for clinicians and ultimately to get into the hands of patients. For clinicians, there are people already using virtual reality in care, and they kind of have this wealth of information and they need to share it, essentially. Going to conferences, sharing information online, and forming coalitions, for example, in order to talk about what patients like, what patients don't like, what works in practice, what doesn't work, and advocating ultimately for how to get these technologies into the hands of people who need them. And industry is going to be a big one here. This can't be one company monopolizing everything in order for a profit margin. This has to be something that is accessible, that is interoperable, and that everyone can use. And ideally, it will be something like open source, something there where no one device limits you into any one ecosystem. So this is going to be, again, something that takes everyone's help and everyone's input, and that's the only way this happens. And we're excited to take steps towards this. That's what I have. It's a lot of information. Thank you for listening. These are my sources. What kind of questions do you have?
Where's the biggest societal need for this?
I would say the biggest need is clearly in people who are, well, I think the immediate need is going to be the people who are developing phobias around coronavirus. These are the things that are pressing and immediate. There has always been a large need for this kind of therapy. Again, with the PTSD, the military service community, their needs are always going to be constant as long as we have a military. And I think it's specifically children are the ones who are being impacted the most by the pandemic. They're the ones who have had their development delayed for years. They've been kept out of schools. All they see, all they know for young people today is fear. So I think young people, children especially, are the ones who are going to benefit most from this technology if it's made available.
Hey everyone, post-production Triton here. I wanted to add to this response that in addition to the military community and to young people today, I think the people who could significantly benefit from virtual reality delivered remotely is going to be frontline workers during the pandemic. These are people who, when the pandemic started, they still had to show up to work in the morning. They still had to stock the grocery stores. They still had to deliver mail. They still had to collect garbage and things like that. So not only just, nurses and doctors and technicians in hospitals, therapists and whatnot, who suffered severe stress during the intro of the pandemic, but the people who didn't get to take a break at all, and who, in addition to the difficulties of work, they had to work through the pandemic, through all that uncertainty. I think there is going to be a large need for help for those populations, and I think we owe it to them. So I just wanted to add that. It was something I thought about afterwards. And anyways, don't forget to like, comment, and subscribe.
Triton, I think you said 3 to 15% of people suffer from a phobia. Do I have those numbers right?
Yes.
I was wondering a few things. Was that pre or post pandemic? And I know you said that a big part is there's a lot of people that don't feel their anxiety warrants going to therapy. Does that include, is that why the number is so broad? Is they're speculating how many are sort of undiagnosed, or that's just who we know, 3 to 15%?
Yeah, that's always the interesting thing about prevalence research in public health, right? It's like you only count the people who want to be counted. So there's always that aspect, but the reason it's 3 to 15% is because those are global numbers. So some countries, it's only 3% of the population that is diagnosed with phobias. In other countries, it's 15%. So those are just like the range of, depending on the country that it's in. And then in terms of the other question, yeah, that's before the pandemic. Right now, we don't have updated numbers, but everyone that is writing on this topic, all the clinicians, all the major World Health Organizations, they're expecting things to get much worse.
The biggest drawback on this is actually the virtual reality goggles that you put on. They are so hard to figure out, so hard to download stuff. I mean, you have to be in Google, you have to be in Facebook. And I think that's the biggest stop to this, is it's so hard to get past that. Is there a way we can Doxy.me this type of process? Can we build our own? You just put the glasses on, press a button, and boom, you're there.
Yeah. That's the usability is the hardest thing right now. And I think the most realistic thing is going to be really promoting open source frameworks for this kind of thing, where I don't need a Microsoft account to then sync with my Oculus account, to then log in through Facebook, to then log into the metaverse or whatever. That's the whole appeal of this metaverse idea, is you need one identity that gets you into every single other place ever, just like it is in real life. You just need your face and your name, and you show up and they know it's you. Right now, the way that technology infrastructures are built is that it's very exclusive. So you have to have a different account for everything, every website you go to. The protocols that they're moving towards is a long-term goal. So that doesn't help us now, like you're saying, Rick, but in terms of building your own thing and Doxy.meing this kind of thing, in terms of making it one thing that goes in, ultimately, to get into that game, you would have to be a hardware developer, and that is prohibitively expensive for anyone. But what we have seen a number of smaller clinic, like these boutique therapy organizations do, is they will purchase a headset from a known manufacturer, like HTC, for example, and then they will partner with HTC to make that device specific for that clinic group's treatment. So the only thing that runs on this device is our app. The only thing that this goes to is our clients, and it's a heavily organized infrastructure for that clinic. So in terms of the short run, that is something that everyone is kind of gravitating towards, these boutique models of, walled gardens. But again, that gets in the way of the other thing, which is everything has to be open. So this is going to be something that develops over time.
It's still very cost prohibitive to users, and that, it's going to oftentimes be one of the biggest drivers or I think barriers to obtaining users, for these sorts of things. And ideally we would get to the point where we can effectively use these virtual reality goggles that you slide your phone into, and it's web-based, and we can have those kind of conversations there, where those things are $15, $15 to $40, and everybody has a smartphone. We just go to the website, get a link, click the link to the website, and we log into the session, just kind of how we have Doxy.me now. But the tech behind that, the software behind that is it's not really there yet, and I don't know that there are open source kind of resources available for these things, but we don't really have like full large teams developing it, and that is prohibitive to us. But that would be, I think, an ideal future for this, for sure. But we'll see.
Thank you. Nice presentation.
Thank you.
Great. All right, well, we're at 10:30, so thank you so much, Triton, for your presentation. Very interesting stuff. We're all very excited about it. And any additional questions, please send our way. And yeah, thanks again for joining us.
Thanks, everybody.
Oh, yeah, good job, Triton.
Good job.